Nigeria and tuberculosis. And so my topic today is CNS TB. Um, okay, so I have nothing to disclose. The learning objectives of the talk today is to discuss on the imaging features of CNS tuberculosis, some of the diagnostic dilemmas and differential diagnosis that we should consider in cases that we come across. So as an introduction, I wanted to focus the data that we have on the African region, as this is the audience that we have today, and an estimated 2.5 million people fall ill to TB in Africa, and about half a million died of it in 2021. In Africa, although we make up 15% of the world's population, it accounts for 23% of new cases and 31% of TB-related deaths, which is a lot with respect to the world population. To make matters more difficult, there's a heavy burden of HIV infection in our continent, and we all know that CNS tuberculosis has a high mortality. It's not just a problem of Africa, but it is a global issue with reemergence of disease worldwide. To compare a little bit between Ethiopia and Nigeria, Ethiopia is considered to be among the 30 high TB and TB-HIV burden countries, with estimated TB incidence of about 140 per 100,000. There is promising results in the incidence of TB, which has been declining, and the decline in TB mortality in the last decade has shown some slower rates as compared to previous ones, as indicated by the Ministry of Health of Ethiopia's report. Nigeria is also among the high TB and TB-HIV burden countries like Ethiopia, and the 2023 progress report of the WHO states that an estimated number of deaths in 2021 in the DRC, Nigeria, and South Africa accounted for about 48% of all TB deaths in the African region. Another WHO released report states that in 2023, there was about 361,000 TB cases in Nigeria. 9% of these were in children, and there seems to be an increase as compared to 2022. So this is what I was able to find on Nigeria just a little bit. And I realized that our demographic and our problems seem very similar. So most of the cases I will probably be showing you are cases that you have come across in your practice. So this is just to refresh your memory, so to speak. Continuing with the introduction, where the pathogen responsible is Mycobacterium tuberculosis, which is an acid-fast bacilli. It starts off in the lung of inhalation of droplets and with hematologic spread to the CNS. There are multiple different kinds of presentations of the CNS tuberculosis, where it can involve the brain parenchyma, causing tuberculoma, abscesses, in-plaque TB, miliary TB, or encephalopathy. It can also involve the meninges and the spinal cord as well as the vertebra. So I'll try and show you as many cases as I thought would be interesting and represent the diverse appearance of tuberculosis in the CNS. So from here on, we will be looking at cases and look at differentials of cases that we have come across. So case one was a patient who had multiple findings involving the posterior fossa as well as the supratentorial brain parenchyma. You can see indicated in the blue arrows that there is a lesion involving the pons, which has a heterogeneous signal intensity and surrounding perilesional edema. You can see that there's also dilatation of the, can you see my cursor, if I may ask? Are you able to see my cursor?
Yes, yeah? yes.
So there's also dilatation of the bilateral lateral ventricles, and you can also see a similar intensity lesion, heterogeneously T2 hypointense lesions with perilesional edema involving both lesions, again, in the supratentorial brain parenchyma as well. T1 weighted image, it appears to be intense to slightly hyperintense, involving the posterior fossa. On the GRE sequence, you can see that there's no significant susceptibility seen in this patient. When you go to the post-contrast images and the diffusion-weighted image, you can see that there's no significant restriction seen in the DWI, and then you can see that there are multiple conglomerates of rim-enhancing lesion involving both the posterior fossa as well as the supratentorial brain, involving the parietal lobes as well as the frontal lobes as well bilaterally. You can see there is effacement of the fourth ventricle as well, which is causing the dilatation of the lateral ventricles in the supratentorial brain parenchyma. This is a companion case of a 25-year-old with severe headache, and you can see that there is a similar intensity lesion involving the posterior fossa, again, the pons. You can see on T2 that there is a T2 dark signal intensity, and then you can also see that there is also the surrounding perilesional edema, causing mass effect and, again, dilatation of the lateral ventricles. On post-contrast images, you can see the thick, irregular, rim-enhancing large single lesion on both the axial and the sagittal images. With the presumptive diagnosis of tuberculosis, this patient was put on anti-TB and imaged 2 months later. And now you can see this lesion is reduced in size, although you can still see the T2 hypointense signal intensity. And you can also see there is significant improvement in the perilesional edema as well. So this is what it looks like on post-contrast images. It looks more of a solid single nodular enhancing lesion at this point. To compare with the pretreatment image that we saw, it had the irregular rim enhancing lesion, and now it has significantly improved in size as well as mass effect and enhancement pattern as well. Another case, this is an adult patient, and you can see involving the right cerebellum, there is a heterogeneous lesion, again, slightly T2 hypointense with perilesional edema, effacement of the fourth ventricle, and you can see also that there is tonsillar herniation through the foramen magnum, and you can see again this ill-defined rim enhancing lesion. Again, this patient with a presumptive diagnosis of tuberculosis, the patient was imaged 10 months later. Now you can see that this lesion is reduced in size with significant improvement of the perilesional edema. You can see on the diffusion-weighted image that there is no restriction on DWI, and you can see how small the lesion is. To compare to the previous image, you can see the size and the improvement in this patient who was treated with anti-TB. This is an older patient, an older case that was shared with one of my colleagues, and you can see these multiple well-defined dark T2 signal intensity lesions involving the bilateral cerebellum. You can also see that there is similar intensity lesions involving the temporal lobe on the left side. You can also see dilatation of the bilateral lateral ventricles with significant periventricular T2 hyperintensity, which could, one, be due to acute obstruction of the lateral ventricles with CSF transudation. And you can also see that there is perilesional edema involving the supratentorial brain. Again, on the diffusion-weighted image, you can see that there is no restriction of this lesion. On the T1 weighted image, you can see that the lesions are slightly hyperintense to isointense compared to the gray matter of the brain. Post-contrast images, multiple well-defined rim-enhancing lesions involving both the supra and the infratentorial brain parenchyma. You can also see that there are small nodular enhancements also involving the posterior fossa. So I wanted to focus a little bit on initially to show you posterior fossa lesions, predominantly in pediatric patients, can be very difficult to differentiate from other lesions. So you're usually worried about tumors in the posterior fossa, and the differential diagnosis usually that we consider in pediatric patients particularly are brainstem glioma, pilocytic astrocytomas, medulloblastomas. So these are the things that we really worry about, particularly those involving the pons. You can have encasement of the basilar artery, which can also occur in TB cases. So you can see the differential diagnosis here, brainstem glioma and the first one. These two images are the ones that we've already discussed. So one involving the pons and one involving the cerebellum, and both were TB cases. And then you have pilocytic astrocytoma as a differential diagnosis. Now, in adults, of course, you have to also consider cases such as metastasis and hemangioblastomas. And we all know that there are different imaging features that we look for, particularly for hemangioblastoma. But metastasis in older patients is very difficult to differentiate from TB, and you need to look for primaries as well as any other tumor markers that you may have. So this was cases regarding posterior fossa tuberculous lesions. Case 3 was a 12-year-old who presented with headache, and you can see this ill-defined lesion involving the high left frontal lobe with perilesional edema. There's also a similar intensity lesion posteriorly as well. You can see in the high parietal lobe. It's behind the central sulcus, so this is the parietal lobe. And you can see on post-contrast weighted images, there are multiple ill-defined enhancing lesions, and some of them are well-defined small rim enhancing lesions in the supratentorial plane. This patient also in the posterior fossa, you can see that there are subtle. Should I continue? Or somebody's trying to speak. Okay. So there are also multiple smaller lesions in the cerebellum as well. There is no significant diffusion restriction. On the CT image on the pre-contrast, you can see that it's quite difficult to kind of make out where the lesion is. The only thing you might particularly see would be the hypodensity that you see surrounding the lesion. So you need to have a high index of suspicion in these cases and recommend MRI. This patient had chest X-ray done, and they were taken 10 days apart. This was the first image, and this is the second one. And you can make out these miliary TB pattern throughout the bilateral lung fields. And you can also see that there's mediastinal widening, probably due to lymph nodes in that area as well. So this was a case of TB with miliary pattern in the chest as well. Case 4 is a 6-year-old who was presented on one of our MDT meetings, and my colleagues discussed this case, and you can see that there's a calcified lesion on the right side, and there are multiple slightly hyperdense lesions involving the left frontal periventricular region, as well as these perilesional hypodensity suggestive of edema. You can see on MRI that there is some rim enhancement of this lesion in this case. MRI was done for this patient. Now you can see how dark these T2 signal lesions are with the perilesional edema. Again, the dilatation of the lateral ventricles in this case. And on the diffusion weighted image, there is no significant restriction seen in these patients. On post-contrast images, you can see the rim enhancing lesions again, but now notice that there is a basal meningeal enhancement, and you can see this pattern, which is quite helpful in making the differential diagnosis for this patient. The patient was shunted, and shunt series was done because the patient ended up developing fever and was eventually intubated and admitted to the ICU. And you can see these large lesions that we saw initially. There is dilatation of the bilateral lateral ventricles. A month later, on December 5th, you can see that there's this wedge-shaped lesion, which is hypodense. These were done for shunt series initially to check the status of the shunt. So post-contrast images were not done in this particular last image, but you can see that there's new development here that was not seen in the initial images. On chest X-ray, on chest CT, sorry, you can see that there is also a lung lesion. So this was a presumptive diagnosis, again, of TB. A patient was shunted, but the new development of these hypodensity made us think of a possible stroke. Could it be post-vasculitis? Unfortunately, this patient was not imaged with MRI. Our MRI is done in our facility, and patient could not be moved from the ICU to image MRI, but this is a new development that you need to look for when you are doing follow-up images of patients being treated for tuberculosis. So tuberculomas, the MRI appearance is variable, and this depends on the maturation and the stage of maturation. So you can have non-caseating or caseating with solid granuloma or caseating with central liquefaction. So this is a chart that I like to discuss because it kind of makes it a little bit easy to follow. So you can have tuberculoma, and the T2 signal intensity depends whether it's non-caseating or caseating. So the ones that we've seen, multiple lesions that I've cases that I've shown you are the solid caseating types where the T2 hypointense signal intensity is one of the features that are easy to identify. On T1, it can be iso to hypointense and usually have rim enhancement. The caseating type with central liquefaction have a T2 hyperintensity. And when you come to non-caseating type of tuberculoma, the T2 signal intensity is usually hyperintense. The T1 is iso to hypointense, but the enhancement pattern is usually nodular enhancements that we see. So, of course, all lesions that have T2 hypointensity is not tuberculosis. You should also consider other differential diagnosis. That's why we also look at the GRE sequences to see if there's any hemorrhage or any calcifications that might pop up as well. So these are the things you could also consider in your differential diagnosis. Now, the T2 hypointense signal intensity that is seen is usually said to be caused by the granulation tissue and the compressed glial tissue in the center of the core. So if you see, particularly in countries where TB is endemic, with T2 hypointense lesions, multiple lesions with no restriction and rim enhancing, and with particularly conglomerates of rim enhancement, the chances are these are going to be TB. As you know, it's very difficult for us in our setups to biopsy all the cases, and a trial of anti-TB is usually started and a follow-up image is taken. Is there a role for advanced imaging? It depends on your setup and what you have. Diffusion-weighted image sometimes in difficult cases can be used to differentiate between different lesions. If you have a caseating type T2 hypointense with central restriction, you should consider cases such as CNS lymphoma. And of course, this also depends on the immune status of the patient. And other caseating lesions, which are actually central liquefaction, which are T2 hyperintense, they're very, very difficult to differentiate between pyogenic abscesses or high-grade gliomas or metastases. Is the role of MR spectroscopy? The literature says there is, but for me, we don't usually do MR spectroscopy in these cases. Your MRI magnet strength should be at least 1.5. I mean, 0.3 MR spectroscopy, the images are going to be very difficult to do to begin with, and also the reproducibility and the evaluation of the MR spectroscopy might be difficult, but there is some role in differentiating pyogenic infections from TB, looking at the lipid lactate and what parts per million it have, you can see it, or to differentiate tumors. Sometimes if you have a very large tuberculoma, it really looks like a mass lesion, and I'll show you other images showing that, and you can use that to look at the NA and the colon peaks that you see in tumors. So there is a role for spectroscopy, but it depends how comfortable you are. I'm not usually a fan of MR spectroscopy, but that's just me. So differential diagnosis for rim-enhancing lesions, of course, toxoplasmosis, as you can see, are one of the things that occurs particularly in patients with immunosuppression. Usually they will have an off-center nodular enhancing lesion as well, looking like an off-center target. A primary CNS lymphoma, you can look at the diffusion-weighted images in these cases. Pyogenic brain abscesses, demyelinating lesions, usually they will have an incomplete C-shaped enhancement pattern, and usually you don't see a lot of mass effect despite the large lesions that you see. I'm not sure how much of hydatid disease that you see in your setup, but superimposed infection of hydatid disease can cause rim enhancement in cases. So these are the differentials, some of the differentials you can consider in patients who have rim enhancing lesion. Case 5 is a 3-year-old with seizure and right side body weakness, and you can see these again, multiple hypointense lesions. I'm trying now to focus on the other findings. Now you can see that there is significant leptomeningeal enhancement seen in the basal meninges as well as the cerebellum. And you can see this coating of enhancement along the spinal cord on the ventral and the dorsal surface as well as coating the cerebellar surface as well. You can also see this large enhancement also extending into the suprasellar region. Case 6 is a 14-year-old girl who had visual blurring of a 1 month duration. Again, you can see these multiple brain parenchyma lesions. Patient had on post-contrast conglomerates of multiple rim-enhancing lesions involving the suprasellar region, as well as the bilateral temporal lobes, frontal lobes as well was seen. This patient was given anti-TB, and she also had significant blurring of vision that prevented her from going to school at the time. And the father brought this patient in. And 8 months post-treatment, you can see that there is significant improvement in the rim enhancement, but now you can see this thick, almost pachymeningeal type of enhancement, which extends also to involve the right frontal lobe as well, with multiple nodular lesions as well throughout the brain parenchyma. You can see this thickened enhancement involving the frontal sulci as well as lesions in the posterior fossa. Now, these are the pre-treatment in yellow, and the blue shows the post-treatment images. Patient had significant improvement of her visual symptoms. She was back in school, doing much better with improvement in her headache and symptoms that she had. But you can see that they were still a little bit worried. The clinicians wanted to discuss this case, and you can see the enhancement pattern has changed to significant pachymeningeal enhancement. This is another patient who had multiple lesions involving the supra and the infratentorial brain, but notice now on the diffusion-weighted image, the ones that we had seen so far did not have diffusion restriction, but in this particular case, you can see that there is restriction, DWI bright signal intensity, and you can see also this restriction appears to be in the posterior horn of the right lateral ventricle as well. And you can see here again in the supratentorial brain. Post-contrast images, again, you can see these conglomerates of rim-enhancing lesion, multiple thin-walled, well-defined enhancements, but you can also see there's basal meningeal enhancement here, and also you can now see that there is enhancement of the ependymal wall of the lateral ventricles as well, and if you see the content of the lateral ventricle in the posterior horn, you can see that the T1 hypointense dark signal in the of the CSF, but you can see now that there is slight increase in the intensity of the CSF as well. So this is a patient who had basal meningeal enhancement with, again, ventriculitis as well as possible abscesses because they had diffusion restriction in this case. A companion case, this is an adult patient. You can see this diffuse T2 hyperintensity, but if you look at the T2 weighted image, it's very difficult to make out where the lesion is. You can't really see much happening here. Perhaps in retrospect, after you see the post-contrast images, you can see that there is some thickening along the left frontal lobe, but I think it's very difficult to make out without looking at the post-contrast images. On the post-contrast, you can see this thick nodular pachymeningeal enhancement involving the surface of the brain along the falx, as well as in the sylvian fissure bilaterally. And you can also see on the coronal images these enhancement patterns. 7 months after being put on anti-TB, you can see there's significant improvement in the T2 hyperintensity. You can see now on the post-contrast images that the enhancement pattern has shown significant improvement. Really, compared to the previous images, you can't really see much enhancement, but there is dilatation of the bilateral, significant dilatation of the bilateral lateral ventricles seen as well as in the fourth ventricle. So TB meningitis, usually you'll have thick exudates, very commonly seen in the basal meningeal enhancement in the interpeduncular fossa, the suprasellar cisterns. Of course, there are multiple other causes of basal meningeal enhancement. It can be pyogenic infection, sarcoidosis, or neoplastic conditions. You can also have pachymeningeal enhancement in these patients. You have to correlate these findings with lab investigations, CSF analysis. These are the cases that we discussed with the thick enhancement post-treatment, as well as the basal meningeal enhancement that we have already seen. Imaging can be normal with patients who have TB meningitis, so the absence of any finding does not rule out TB meningitis. I usually like to report that at the end and put a statement in there saying that the absence of enhancement or the normal imaging does not rule out meningitis, and that they need to check with the CSF. The other important thing is also to look for complications. So what kind of complications can you see? You can have progressive hydrocephalus, which is usually caused by obstruction of the CSF due to the exudates. You can have vasculitis or vascular changes. Strokes are common. In about a fifth of cases who have stroke, it is said to be commonly involving the basal ganglia, the thalamus, the brainstem, as well as the cerebellum. Cranial nerve neuropathies, commonest cranial nerves involved are usually 2, 3, 4, and 7, and they can have thickening or T2 hyperintensity, and they can enhance on contrast images. You can see the diffusion restriction in this patient who developed a stroke post-infection, and you can also see in the basal, the head of the caudate as well as the basal ganglia as well. And you can also see dilatation. So these are progressive hydrocephalus that can occur. And most of the cases that we've seen that most of them had hydrocephalus either before treatment or after treatment. So these are the things you should consider. Case 8, I always find this case very interesting because, and I've shown this case multiple times because I've only seen 2 cases, similar cases like this. The patient presented with a change in mentation. She's a 47-year-old female patient of 1 month duration. I'm not going to really focus a lot on the T2 signal intensity and the enhancement patterns because we've discussed that. But if you have noticed, you can see that there's this focal hypo-intense lesion involving the right eye globe on the posterior surface. Differential diagnosis to consider, of course, considering her age and the presentation, you can consider metastasis as top differential diagnosis. Patient had a CT of the chest done. There's this mass-like consolidation with air bronchograms and interstitial lung findings with free in bud appearance. I'm not really very good at chest CTs. I consulted our chest imagers on this case. Patient was put on anti-TB. Post-treatment, you can see there's significant improvement in the lung findings. This patient, of course, the differentials to consider would be a lung pathology, such as lung CA with metastasis to the brain and the orbit. But this patient had this significant improvement post anti-TB. She couldn't afford to get the CT or MRI of the brain done and wanted to wait until completion of treatment before doing that image. So ocular TB, tuberculosis involving the orbit, is very rare, said to be very rare, even in endemic areas. I reached out to our ophthalmology department and asked them how frequently they see this. They say it's exceedingly rare. And it's very hard to diagnose and treat and requires a high degree of suspicion. And usually they present with non-specific symptoms, commonly presenting with uveitis. And these are some papers if you want to read more on ocular tuberculosis. So another case was shared to me by colleagues where they had similar findings in a pediatric patient who had calcification in the orbit as well, in the globe, which responded post-treatment as well. Case 9 and the next few cases I wanted to show you are interesting cases where this was a 19-year-old with left side body weakness, and you can see this mass-like large T2 dark lesion with perilesional edema, effacement of lateral ventricles, and a midline shift and dilatation of the contralateral ventricle as well. This is a companion case, similar findings, peripheral-based T2 hypointense lesion with edema, enhancement pattern, which is heterogeneous. You can see a suspicious lesion that appears to extend like a dural tail over here. Patient, the neurosurgeons went in and operated. Presumptive diagnosis initially of TB was given by my colleague, and there was a doubt in the diagnosis. They were considering meningioma as a possibility and went ahead and operated this patient. Pathology result came back as being TB. This is a very interesting case that we saw maybe 7 years ago or so, who's a 10-year-old boy who came from a periphery hospital. Patient had the CT scan where he had this large heterogeneous lesion with calcification. Looked like the calcification maybe follows the gyri. There is significant mass effect, perilesional edema, again, the dilatation of the contralateral lateral ventricle. MRI showed again this really strange lesion enhancement pattern, looks fluffy, very heterogeneous. We could say some areas look like there are rim enhancements. Differential diagnosis of possible supratentorial ependymoma was also given at the time. Patient was operated, ended up coming back as TB. This took us by surprise. Patient did quite well following his operation and also treatment with anti-TB. I want to say a few years ago, we reached out to him. He's still alive, doing well, although he remains blind and has seizure and is on follow-up on seizure. So these were cases that usually who are peripheral based and quite large and look like a mass lesion. They can be very, very difficult to diagnose. And the differential, particularly if you have an adjacent compression of the meninges, it can look like there's a dural tail, which can be confusing with meningioma sometimes. But all these three cases that I showed you were TB cases and not other lesions such as meningioma. So these are interesting cases that I wanted to show you that appear as having mass-like lesions that can be difficult to differentiate from tumors. Case 10 was a young male patient who presented with headache, but he also had imaging done of the spine. We're not sure why the imaging of the spine was done. You can see the multiple rim-enhancing lesions in the posterior fossa as well as the supratentorial brain. Patient was started on anti-TB, considering the T2 dark signal intensity, the enhancement pattern, and 2 weeks later, patient came back with paraparesis. You can see now on the spine that there is a significant posteriorly dorsally enhancing thick long segment enhancement, which is also causing a mass effect on the cord. It's difficult to tell where we are because we can't see the C2 vertebra, so we can't really count where we are. And then you can see these subtle findings in the vertebra. This was seen in retrospect. These were the images of the brain done for the same patient at the same time. These are the images that I showed you initially with the pre-treatment images. You can't really see much. Maybe perhaps you can see these subtle lesions involving the vertebra. If you had a high index of suspicion, you might consider lesions involving the vertebra as well. And this was a patient who ended up having this finding post-treatment. This is a companion case of a female teenager with headache. You can see again this ill-defined lesion. You have the basal meningeal enhancement and pachymeningeal enhancement. Patient was started on anti-TB. 6 weeks later, patient came with worsening of symptoms. Now you can see that there's significant increment in the perilesional edema. The enhancement looks worse, looks really ugly, really thick. The pachymeningeal enhancement is worse. You can compare the pre-treatment with the post-treatment, where you have these images comparing the yellow is the pre-treatment 6 weeks before. Now you can see how thick the enhancement is, and it looks really, really bad now. So what is this? Paradoxical worsening. Paradoxical reactions are usually worsening of pre-existing lesions or development of new lesions when a patient is on anti-TB. The precise pathophysiology is not really known. The duration after initiation of anti-TB, different literatures say different things, but the main thing to consider in these cases is what could it be? Is it paradoxical worsening? Did we get the wrong diagnosis to begin with? Or is this patient having some sort of drug-resistant TB or MDR TB? Or is the patient having failure to take the medication, the appropriate medications on time? With the DOT system, that's very unlikely to be a failure to take the medication. It could be MDR-TB, but it doesn't mean that all worsenings are necessarily wrong, and you should not change your diagnosis based on these findings, and you should stand your ground sometimes, and you should not despair, and you should continue with the treatment if you have good enough evidences for TB to begin with. Of course, imaging, CSF analysis, gene expert, all these things can also help in the diagnosis, but how many of us do gene expert for all CSF or for all CNS TB patients? And how many of us biopsy these cases? So that's a question that we have to ask ourselves. Deep-seated lesions, we almost never biopsy it because it's very difficult to biopsy. CSF analysis with gene experts can be done in these cases. So these are the things to consider. Considering our HIV and AIDS population, immune reconstitution inflammatory syndromes are one thing. I mean, if it's helpful if the patient's immune status is known, could this be related to HIV? Is the patient on ART and all these things? It depends what kind of information you get. If you get patients who are coming from outside referrals, you might not necessarily have this information. But I just wanted to touch upon on this. It's very difficult to cover HIV, AIDS, and TB at the same time with this amount of time that we have. But I wanted you to be aware of paradoxical TB reactions or iris. Is it paradoxical or is it unmasking? This depends on initiation of ART. Is it before the TB treatment or after? And all these are the features that you need to look upon. You can read more on this as it is beyond the scope of this presentation. So case 11, I just wanted to touch upon one finding in this patient. You've already by now seen enough cases of these T2 dark lesions with rim enhancement, so that is not the purpose of this case, but rather, the upper neck is sometimes included depending on your text. This is great because the patient had multiple lymph nodes involving these bilateral neck, and you can see the rim enhancing lesions in this case bilaterally. So this patient also had lymphadenopathy. So if you're confused about whether could it be pyogenic infection or not, then you have these multiple rim enhancing lesions involving the neck, likely to be disseminated tuberculosis. Case 12 is a young child, and you can see multiple findings in this patient. In the interest of time, I will show you the findings. You can see that there is L4 and L5 vertebral involvement with T2 hyperintensity. There is paravertebral soft tissue swelling, and you can see also epidural collection, which is causing a narrowing of the spinal canal at that level. You can also see multiple abscesses involving the paravertebral soft tissue, on the left side. You can also see multiple rim enhancing lesions involving this patient. There's one finding that is quite helpful to make you consider the differential diagnosis, is that you also have these lesions in the lung parenchyma as well. You have epidural abscess on post-contrast images. You can see that there is rim enhancement. Of course, you also have the abscesses involving the psoas, as well as potentially you can also see that there is rim enhancing lesions in the abdominal cavity as well. So this was a disseminated TB. You can see lung as well as vertebra and epidural abscess and psoas abscess seen in this case. These are very, very common findings I'm sure you've come across in your practice, where you have back pain of patients presenting. This is a patient who had back pain of 6 weeks duration with right leg radiculopathy. You can also see involvement of the bilateral vertebra, paraspinal soft tissue, epidural abscess on rim enhancing lesion, causing spinal canal stenosis or narrowing. And of course, you have this coronal images. I like to see those because they really show you the extent of the psoas abscess in this patient. Also, you can also make it out on the axial images, but I like looking at the coronal images. And this is a case of spondylodiscitis. This is another patient who presented with radiculopathy, and you can see that this patient had extensive T2 hyperintensity involving the cord extending to the cervicomedullary junction. You can also see there's expansion of the cord. If you compare the lower aspect of the cord compared to this region over here, C3, C4 level, and on post-contrast image, you have this thick enhancing lesion with a slight non-enhancing center. So it looks like a thick rim enhancing lesion in this case. CT was initially done for this patient unless you really had a good eye or you were not looking at this. This is not your last case where you're tired. You might miss this lesion as it's slightly hyper dense, but if you don't have a high index of suspicion, you could easily miss this case. So these are the findings that you saw in this patient. A companion case. Can somebody mute their mic? Okay. You can also see similar finding in this patient. There really is There isn't much cord expansion in this case, but you can see this T2 hypointense lesion, extensive T2 hyperintensity above and below the cord, extensive edema in this case, and post-contrast images, you can see that there is rim enhancement of this lesion. This is much easier to make out. Very dark T2 signal intensity lesions, extensive edema extending all the way up until, it's cut, so you can't really see the upper level of extension of this lesion. Post-contrast images showing rim enhancement involving the cord. So all those cases were TB. Now, the differential in this particular patient was a 9-year-old boy who came with paraplegia. He was treated with anti-TB and showed no improvement. In this case, you can see involvement of the vertebra. Kind of looks like there is some shaggy outline to the vertebra as well. Hyperdense striations and hypodensity involving the vertebra, the spine. And on MRI, you can see it's a T2 hypointense, but you can see this extensive, thick, enhancing lesion anteriorly and posteriorly, causing significant narrowing of the spinal canal. In this case, patient was biopsied eventually, as there was no improvement despite the anti-TB treatment, and the diagnosis of primary non-Hodgkin's lymphoma was made in this particular case. This is another case that I really like to show. It's a 9-year-old boy who presented with acute paraplegia. And you can see the subtle lesion involving the cord with expansion. And this was a case of schistosomiasis as well. And you can see on the post-contrast image, you really can't make out that rim-enhancing, well-defined lesion that we saw involving the cord in the TB cases. So spine TB, you can have spine spondylodiscitis involving the vertebra, the disc space. You can have skip lesions. You usually have paravertebral soft tissue, psoas abscess, epidural abscesses are also seen. You can have cord TB, where the T2 dark signal intensity and rim enhancement are features that you usually see. Of course, you should also consider, again, multiple differential diagnosis in these cases. Metastases, low-grade infections, fungal infections, sarcoidosis are differentials to consider, and of course, lymphoma in that particular patient that we saw. Final points, impact of COVID. There was some negative impact on TB services indicators in Addis Ababa in Ethiopia, with some publications coming out saying that there was some resistance to rifampicin seen in patients because of interruption of services caused, which could potentially have affected probably Nigeria and other African countries as well, where this might have had a significant impact of TB in our continent. There are multiple publications you can read on, and I'm not sure what the effect of COVID was on TB and Nigeria. Probably with the increase in numbers, it could be related to that. I'm not sure. Don't quote me on this, so I would love to hear your thoughts on that. So the take-home message: TB endemic area, consider treatable causes of cases when you come across CNS tuberculosis. Making a diagnosis of pontine glioma versus pontine TB, the outcome is quite different if you compare the two. We can treat TB, but even in the best of centers, it's very difficult to treat tumors in the brain. TB can have variable imaging appearances, as we've seen, and that is something to consider. The T2 signal intensity is one of the most helpful signs that you can see for CNS tuberculosis, for tuberculomas. Worsening of symptoms is not equivalent to wrong diagnosis, so keep that in mind as well, and consider IRIS in TB or TB and HIV and AIDS patients in our population. So thank you. This is Addis Ababa, and maybe I'll see you in Addis one day. So thank you very much.